One thing that we'll do a little bit of in lab today is we'll do what I call blending, making sense of all the stuff. Because your patient, I don't know if you ever read your patient's chart closely when you were in clinical. Most times patients don't have just one diagnosis. Patients have multiple diagnoses and they have history of other things. They may not be in today for that, but they may be in for gastroenteritis, but they had a history of hemophilia. They were diagnosed hemophilia. So how would you blend those two things? So that's what we should be doing in this semester, and we'll talk a little bit more about that. So when you say I stick to my objectives, yes, I will. But just know that anything else that you've learned, growth and development, it's not in the objectives anymore, but it's assumed that you understand that that is always going to be in your question. Same thing with your lab skill. Calculations for medications for fluid. That's fair game. So anything you've learned before, you can't forget. Yeah? Yes, Tina?
Honestly, I read the whole hematology chapter last night. Today I focused on the 3 points of focusing on. Is that all we should focus on in that chapter? Or
whatever your objective said, those 3 conditions.
Anemia, hemophilia,
That's right. Yeah, that's it. All right. So if you have your clinical manual, you can take it out. Take out your clinical manual if you have it. Sickle cell anemia, iron deficiency anemia, and hemophilia. The 3 things in that competency. Oh, you have the ebook. Yeah. Do you know how the page numbers do they correlate to the hard copy?
Yes.
So, okay. So if you go to the clinical manual, page 68, it's in the same thing.
Yeah.
That's the newer assessment. Let me see.
Because I have a PDF version.
Ah, I see. See mine? So,
You can fix it. She has an ebook. So make it look like this.
yeah.
She can do it.
Fix it to a PDF? Oh, yeah. Okay, so, I'm in the right book here. We're going to the assessment unit 1. Page 68 if you're in your clinical manual. So when you're looking at your assessment of individual with a neurologic deficit, your adult patient, tell me, what things do you look at? What things do you include in that assessment?
You assess from the head if the patient is alert and oriented.
Okay.
And you look at the eyes. Like, they have this acronym, PERA. And we also look at the motor functions and the sensory functions. And also look at reflexes.
Can you guys hear her down there?
No,
She's speaking. She's talking secret over here with us.
we can't hear anything.
Yeah. So you're right. So just tell them. Say what you were saying.
So when you go into a patient's room, your first assessment, it's how the patient looks. That's if the patient is alert and oriented, and you look at the patient's facial expression, which is under the cranial nerves. Then you also assess the motor functions, like, you can keep your hands like this and ask the patient to, push your hands behind. You can also assess the sensory reflexes, the sensory motor system, the gross motor. You can also assess the, did I mention reflexes?
You said it.
Yeah.
So the thing is, when you're doing an adult, tell me. You say you're gonna check to see if the level of consciousness, if they're oriented. So how do you do that? What do you ask them?
You can ask them, what is today's date,
Okay,
or what is
the
the name
date.
of your president,
This president.
or what is your name,
What is
or
their
why
name?
are you here?
Why are you here? Or where are you?
Do you know where you
Okay. So when we take that information that you already know, and we have a baby who is between birth and 6 months, and you're doing your assessment, what things do you want? How would you assess orientation for that less than 6 month old infant?
You assess the behavioral aspect of the child. If the child can play or can move around, or if you're assessing the like the eyes, you can maybe point something to the eyes or by the side and see if the baby is going to turn towards what you're pointing at.
So basically, you're trying to see if they're acting appropriately, right?
Yeah.
Are they acting appropriately for their age? So you need to know what's appropriate for their age. You need to know that babies less than 6 months don't have separate anxiety yet, so they'll let you do any and everything. You need to know when those reflexes leave. So if you go to page 24 of your clinical manual, you'll see the newborn reflexes. Page 24. And you look at the newborn reflexes, and they tell you most of them should be gone by 4 months. Okay? So if I'm doing a neurologic assessment and I have a 6-month-old or 5-month-old baby that is still holding on to some of these reflexes that should be gone, is that cause for concern?
Yes.
Yes. I need to further assess that. Okay? So some of the things that you look for in your assessment, she mentioned. So those reflexes are important when they're born, right? And what are they? What are those newborn reflexes?
You have the grasp
How do you
reflexes.
listed them? The grasp reflex.
You have the
So
motor.
if I put something in your hand, you hold it. It's strong, aren't they? Those babies are strong. You try to take it out and you're like holding on for dear life. Okay, so the motor reflex is what?
Like when you try to lift the baby up and you put the baby down and the baby is startled and brings the hands to like a
So
position.
it almost it's also called the startle reflex, right? So you're lifting them up and you let them go and they go. Okay, like they almost want to huff themselves. That's normal. You want to see that in the newborn. When should that be gone?
By 4 months, that should be gone.
So how about the fencing? Tonic neck fencing. Fencing. You know that reflex? Never learned that?
No, we did. Fencing should be done by
No, I'm thinking. When is it supposed to go?
fencing.
It's 3 to 4 months. So it should be gone. Yeah. And then the other one that you want to think about is rooting and sucking.
What?
Rooting and sucking, right? Because rooting is important for me to suck. I need to find it to suck it. So if you stroke my cheek, I turn to that side, open my mouth, and make sucking motions. That's rooting. And of course, sucking is sucking. Then the other thing you need to realize is what gross motor skills should this child be able to do? So when I'm 4 months old, when I'm 2 months old, when I'm 6 months old, what gross motor things should I be able to do?
Baby should be able to sit by 4 months. Sit with support.
Sit.
With support.
It's 8 months.
No,
I mean,
4.
8 months is
No, 4 months is early.
6 is walking.
Really?
By 4 months, sit with support.
No in the book.
Oh.
Our baby, no in the book.
It's your baby.
Yeah, I'm telling her, no in the book. It's not there in the book. 4 months, the baby has to be sitting.
Sit with support.
Maybe we support the hair and all that.
Really?
No 4
Let me
months.
see.
No 4
Can we
months.
find that?
Same.
No 4 months.
Can we find that?
No,
No,
10.
the baby is starting. Okay.
4, not 10.
10 is not.
Oh,
Where is it? What page is it on?
This is
They're sitting. What page is it on? I'm in here. Oh, I need to go to broker developer. That's what I need. So where is it? I thought you had the page when you were talking.
132.
No.
You didn't? How did you get that?
Who the heck?
132 in what book? The clinical manual?
Yes, 134.
34.
134.
134?
Government development.
Yeah. All right. So there you go.
yeah.
That's what I was looking for. So you said they sit.
Yeah, 4
Where's it
months.
sit?
Able to sit erect.
They say
if
has
prop-
almost
Huh?
no head hang when pulled. To
Balance
sit in
his head.
position. Balance. Okay. Able to sit erect
The baby
if
will be
proper.
able to hold
If
it.
propped up.
Balance his head in sitting position.
Able
So
to raise
yeah.
head.
we're able to sit erect if propped up.
Yeah, if propped
Okay.
up.
So when you say sitting, you're
With
not talking
support.
unsupported sitting.
No, I said with support.
Oh, okay. I didn't hear the with support. That's
No,
why
I
was
kept
asking.
saying that.
That's 4
With
months
support,
early.
yeah.
That is 4 months early. Sitting with without support is 8 months.
Yeah, that's what I said everybody. Yeah. 8 months. I know.
Yeah.
I know. That's
Yeah.
what I
8 months, my baby's here.
No, well, that's what the book said. 8 months. Without
Pediatric
support.
course is not built on your baby. I told you guys in the beginning, if you pay attention to what your child does, you'll feel your growth and development pieces because your children are differently stimulated. So they may be faster. So you can't look at your baby and say, oh, they did it this time, so it must be the right answer.
See,
So no.
8 months sits unsupported, not with support.
Yeah, on support.
Yeah,
That's what
8
I
months
said. I
is
said with no
unsupported.
support.
That's why I was saying when you said that, I didn't hear you say
No, I
supported.
said with support.
Okay, all right. Okay, so when you look at this, you said 3 months, it says primitive reflexes are fading, right?
Yeah.
And look here,
What
4
page,
months,
please?
more reflex, oh, the same page you told me,
134.
134, in that first column. Under the ages, it's telling you about reflexes, right? So the key here is, if you have a 4-month-old baby, you expect that most of the newborn reflexes should be gone. So if I'm assessing a child and they have those reflexes, I need to look closely at them. Okay? Go back to my page 68. All right. So we said there, and of course there are other reflexes, but you don't need to go into all of those details. You can look here. If you look at your book, it says mental status, motor functioning, sensory functioning, and reflexes are the big four. But they're talking here about assessment of the child. So I don't want you to confuse that with the infant. I'm on page 48. The child is 24, newborn, right? And then over here on page 134. When you look at the infant and newborn, will be page 24, and then again on page 134. On page 68, they're talking about assessment of the child. So you can see that you begin to look at other reflexes, deep tendon reflexes. On page 68 is where I am. You look at the assessment categories, mental status, motor functioning, sensory, and reflexes. You guys see that? Are you there on page 68?
Yes, we are here.
And then it goes on into the cranial nerves. Okay? Okay. So then we know that. We look at the child's history. We know this child's age. We know what it should be for the developmental stage, and we figure out what gross motor activity they should be doing. All right. So if I have a 4-month-old baby, what's the gross motor activity that I want them to accomplish between age 4 and 5 months? What should they be able to do by 5 months? For gross motor development. Go back to page 134. I think that helps you. What should they be able to do?
Play with the hands and put clothes in or
So if we look at 4 months, that's on page 135. It says the child has almost no head lag. You know what head lag is? Okay. So they have really good neck support now. They can pull themselves. If you're pulling them up by the hand, they can actively pull with you. They can balance their head well if you support them. They can raise their hand and chest off the surface. So if I put them down prone, they can put their hands down and come up to almost 90-degree angle. So that's pretty good. And they can roll. You see that? From back to side. Okay. All right, so they do that first, right? Back to side comes first. Then we go to 5 months, and we see that this child has no head lag, that they can hold their head erect and steady when sating, so their head is it's no longer bouncy. When I hold up a 3-month-old baby, they might be trying to control their head, but it's still shaking. This 5-month-old, you hold them, and their head is steady. Don't bounce anymore. Their back is straight. They can turn over from abdomen to back. So I put them down prone, I come back, and they're laying on their backs. Okay. So you can already see that back to sleep around 4 months is going to start being a challenge for you, the parent, right, or the nurse. As you put them to sleep on their back, they roll to their side. You put them to sleep on their backs, then they can begin to roll from abdomen. You put them to sleep on that. You put them down the abdomen to play tummy time, and they get tired and they just flipped over. It's like I did it. So that's what I'm talking about when I say what are they supposed to be doing. Okay. Voluntary grab starts around age 5 months. That means if I show you something, you can open your palm and you can take it. That's voluntary. Okay. So they need to be able to do that. So this will help you. You know, you say, how do I know what's normal for that age group? Well, if you kind of look at this growth and development, it comes back again. And it helps you understand what it is that we need to be looking at and for what age group. Okay? Now, when you think about your 6-month-old babies and older, what is one thing that you're concerned about when it comes to that age group?
Safety, because
they're rolling about. So safety becomes an issue. What else?
Accidents like calling to pick up things to put in their mouth.
Okay.
choking.
Okay. What's one thing that you know that all babies around 6 months develop? And it impacts how you interact with them.
To be able to recognize you.
Yeah, they recognize who's in their family. So they develop what?
Anxiety.
Stranger anxiety, right? So they have stranger anxiety around age 6 months. So if I have an 8-month-old baby and the baby's admitted to the hospital, I'm going to take care of this baby. I go to do my assessment. I say, oh my God, I know this baby's not going to want to come to me, not want to see me. I walk in the room and the baby looks at me and smiles, and I reach out and the baby comes to me. Is that abnormal?
8 months.
8 months?
Shouldn't they have separation anxiety? Shouldn't they be afraid of me?
No.
Not babies, that's right.
Yeah.
So what is it about this baby that makes this baby different? Can came to me. He didn't know me from Jack. Just saw me for the first time and came willingly, sat on my lap, huh?
With your mom?
Yeah, he's been exposed to other people. So if I say to the parent, flip it now, flip it. Well, here's another 8-month-old who is afraid of me. That's normal, right? Okay. If I have a 4-year-old, because separation anxiety, according to your book and according to the theories, goes from 6 months to 3 years, right? So if I have a 4-year-old child who is afraid of me, is that abnormal?
No.
Is that a neurological problem?
No.
4 years old.
It's not.
Yeah.
Why not?
It is.
Is there a neurological problem because that 4-year-old is afraid of me? Why not?
Maybe because of the same reason they're not exposed.
That's right. I stay with mommy at home all day. Mommy is homeschooling me. I'm gonna stay at home, baby, only with my family. We don't go to the mall often. I don't get to see many different people.
Yeah, that's my kid is like that because we don't. We're home most of the time.
Yeah.
Even if I take her to like
The
a
park?
Christmas dinner
Uh-huh.
with my family and people, she has a fish. She's like right underneath me, like,
Yeah.
mommy, I can't do this to many people.
Yeah. I have to tell you, my daughter lives overseas. She lives in Dubai. And she and a friend of hers, who is a stay-at-home mom, went shopping this weekend. She called me and she was cracking up. My daughter's an early childhood specialist, so she understands growth and development. She said, Mom, you'll love this. Let me tell you what happened. Her friend has an 18-month-old baby boy, right? So they went into the store, and he started crying. He's in a stroller. He started, she said, really screaming, crying. And she's like, oh, what's wrong? Mom said, well, maybe he's wet. So she took him out. Yes, he was wet. She changed him, and they walked around the mall. He was fine when they were in the mall. And they went into the next store, and the baby started screaming again, same screaming, crying. And Mom said, well, maybe he's hungry. So she gave him his bottle, and he hit the bottle, don't want the bottle. He's screaming. And my daughter said, I looked around, Mom, and I realized the child was scared. She said, we were in abaya. I don't know if you guys know who abaya is. Abaya is the outfit that most women in the Middle East wear. It's you cover up from here to here and to your ankles.
Oh.
And they're usually long. Most of them are black dresses.
Exactly.
And even though they may have stones and all these pretty things, she said, but I looked around the store and all these things were hanging. And then there was a mannequin that had the abaya on, and she was veiled. So the poor child looked at the mannequin like, oh my God. Wow. So was he abnormal? No, he was scared because he didn't know. He doesn't, same thing, don't go out. Mom stays at home. So my daughter thought she was doing something nice, for her friend. Said, come on, let's go to the mall, take the kid, walk around. She said, I felt so bad because we traumatized that kid. He was scared. So no, just because the kid's not coming to you doesn't mean he has a neurological problem, okay? When should kid tie their shoe? Around what age should they be able to tie their shoe? It's a big skill.
2 years.
What?
Is it 6? 5, 6.
Yes. By age 5 they should be able to.
5 years.
So you know
5,
it takes
6.
a lot
I
of
have to stand
dexterity
on
to
it,
tie
my
something,
brother,
right? So remember, development happens cephalocaudal, maximal distal. So this comes last, and I need fine motor skill to tie that shoe. And we teach them all kind of little tricks. Bunch it up here, bunch it up, twist it together. It works. So just because I'm 6 and I can't tie my shoe, do I have a neurological problem? No. Because nobody
It's not exposed to that.
exposed me to it. Mommy and daddy keep tying my shoes because they're always in a hurry. Yeah.
When you go,
That's right. Save the parent.
you have to set it
Shoes
in the
off.
computer. We just set it.
So
Okay,
my point is with assessments, you have to find out from the parents, number one, how much is the child allowed to do. So when you're looking at toddler, preschool, or school-age kids that should be doing certain things, remember what I said, you're going to look at what's normal for their development, but you have to also stop and think, have they had the opportunity to learn that? If I'm a 6-year-old but I can't write, you give me a pencil and I do this. problem.
Yes.
Because you should be in school, number one. Number two, you should have enough dexterity to hold the pencil steady. So even if you're drawing something, you should be able to outline edges. You should be able to make circles. The scribbling business, that's my toddler, right? And my young preschooler. So that's the crux of what you want to do with your history in your assessment. Then you get to your actual physical assessment, and you want to see a couple of things. You want to remember that we're going to look at muscle tone. As you notice in neuro, you learn something. You learn at least one condition that impacts tone. Which one is that?
Dehydration.
Tone, muscle tone.
No,
See?
cerebral palsy.
Cerebral palsy. Those children have movement posture issues because of their muscle tone. Okay? What do you know about the muscle tone of the newborn? What would you say in one word?
It's not developed. It's not well developed.
No, I'm looking for you. Tell me what position do you see them in when they're
Hmm?
flex, right? So they have, you can say tonic, but tonic is kind of abnormal. You think abnormality when you say tonic, but they have a position of flexion, right? So the baby loves to be flexed. So if I have to come in here and do anything with this baby that requires me to extend their arms, extend their legs, are they going to be happy?
No.
No. So is it normal to walk in and meet them all flexed up? Yes, that's what we want to see. If I have a newborn who's laying, looking like this baby, is that a problem?
Yes.
Yes, that's a problem. This baby has probably hypotonia. Muscles are not responding like they should. And if I try to flex the baby arm and it go right back extended, yeah, I may have something cerebral going on. So I want to then look more closely at this baby. So just from posture, I'm already getting a sense that I may have a problem with my baby's central nervous system. So once we do that, we look at the child. You said just by looking, you can see behavior. I can see if this baby is alert, if he's awake, if his eyes are glassed over. I want you all to sit him up because I want you all to come around, those of you who are further away, and see. I want you to take a look at this baby's eyes and tell me what you see. I'm going to turn him this way first, so wait. These guys over here, up first. Look at those eyes.
The roll of ICP, right?
Uh-huh.
Do I get
Yeah. Yeah, all right. Look at those eyes. Eyes can tell you a lot. Like, you notice that you don't see much of the dark part of this baby's eye. You see most of the white sclera. So his eyes rolled up. This is called the setting sun. You read the book, and you saw setting sun or sun setting eyes. That's what they're talking about. That's what they look like. Yeah, yeah. So that eye is telling you something. What do you think his neck is telling you? His posture. You're trying to sit him up.
That's what after
Doing this.
and then like the
Yeah. Pistonus.
yeah something.
Pistonus.
If I saw the word, I'd be like
Curve. Yeah.
that's
Arching. Okay. But he also has hyperextension of his head. Okay. If I were to try to flex this child's head, I couldn't. And it could be because he has meningeal irritation so bad, or he has some cerebral anomaly going on. Could be meningitis here, okay, that has his neck so stiff, he's hyperextending because it's a position of comfort. Or it could be that he has some meningeal irritation. Okay? So I'm not going to try to flex his neck. I'm just going to note that because it is painful. These babies, I'm doing this because I'm teaching you math. I have to move the baby. But if this was to do a real thing, I wouldn't be moving this baby because just even when the baby is crying and you try to hold them to console them, it's more painful because of their neck and the body aches that they have. Okay? The other thing is, if they have meningeal irritation that bad, touching them sometimes can make them sneeze. So just picking the baby up to try to console them, it can make them For those reasons, parents may not be able to hold their baby, so think about those parents. You're caring for the baby. Baby is that sick, I can't even hold my baby, I can't even touch them because they might see us, okay? So this little guy has, let's say he had meningitis, so he has a stiff neck there. His fontanelle, when we look at the head for assessment, we know we have two fontanelles, one here and one back here, right? When do these things close?
Rears a month and a half to the front of the ear.
Okay, so when we're doing an assessment on a 2-year-old, do we need a head circumference?
No, facial flush.
Alright, so make sure all be gone. So I want you to assess that fontanelle. I want someone to feel it. You have a baby, right? I'll come bring your baby to class so we can touch the touch it. Touch it. Yeah. It's bulging. Yeah. You can't even tell because it's bulging.
Yes, I did.
Alright, so it's bulging. So if I were to release that, and sometimes if I pump this up this way, you can see it. See it? Yes. If you look from the side, you can see it. From the side.
Twist.
You see the bulge. And this is not uncharacteristic. You can see this in a real infant. It has bulging fontanelles. It bulges just like this. The other thing it does when it starts bulging, it stops pulsating. Because if you notice healthy babies when they're sitting, just it's like, what's that? There's all the vessels here. It's the blood flow that's causing that pulsation. And when it's bulging like this, there's so much tension on those vessels, they're not pulsating as much, so you don't see that pulsation. Okay? So this little guy has bulging fontanelles. Now, what are some things that can cause bulging fontanelles? Okay, so ICP. One. Now, bulging fontanelle is a very, very big sign of meningeal irritation. Why is it true that, and I like football, so I'm going to use a football analogy. How are you laughing? You see Nada left us? You're so mad at him? Huh? Are you a Cowboys fan?
She's a Raven.
I fly purple.
Oh my.
I bleed purple, I fly purple. Anyway, when those guys get hit during the game, you're watching on TV and they go, boom, and you're like, ow. It's almost like it's instantaneous, right? You and I, we were to go, heaven forbid, walking out to our car, we fall, we hit our head on that hard pavement, out like a light. It's instant. Because our brain got rattled and it's responding already. It's swelling a little bit and we are showing symptoms. These guys, they don't. They don't. Why don't we see that same reaction when they start to have increased intracranial pressure? You don't see that immediate response, decreased level of consciousness. It happens, but it happens over time. You don't see it drastically as you would in someone who's over 2. Why? They have more room because of what? Because that's right, the fontanelles are open. And see these guys right here, remember in OB? The sagittal sutures, the parietal sutures, remember those guys? Yeah, they're open. As long as that fontanelle is not completely sealed, those sutures are still open. They're closing, but they're not completely closed. So if my hands start to swell, I can push out against them and force that brain to give me some space. I can bulge out here. So I don't have the same amount of pressure that you have as an adult with a cranium that's sealed and closed so that you have that instant reaction. So this guy, by the he's at his max. He's been doing it for a while. So it's not a baby that you can say, oh my God, don't you fucking know. This is a baby that's, oh, PICU time. We're going to the PICU. This baby's going to stop breathing on us just now. We need to really get this kid in. We need to figure out how to take care of that pressure on his brain, whatever is causing it. And we need to support his airway so he needs to go to the ICU. Okay? So that's the one of the big difference that you'll see with your pediatric patients younger than 2 years. Because of their fundamental, they have room for their brain to swell before you see symptoms. Okay? So we had a kid, if this kid had, and here's a scenario, this kid came in, he was diagnosed, his initial diagnosis is gastroenteritis. Okay? He has history of vomiting and diarrhea, but he also had a history of having spinal bifida when he was born. He had a meningocele and he was pink. He had a BP shunt. All of this was done before he was 30 hours old. So now he's in the hospital. He's 18 months and he has gastroenteritis and he's been vomiting, he has diarrhea, he's a fever. You're doing your assessment. What things are important? Yeah. Okay. Okay. His shunt is in his ventricle, so I may be able to feel his skin, so I can feel it. Okay. What else?
But that depends on where he has the shunt against the
You know, most times with infants, that's a good question because you can do VA, ventricular aortic, but you hardly see that with young infants unless that's the only option they have. Why wouldn't they put this fluid into the aorta? Well, it's developed, but it's not able to handle that extra fluid, right? So we don't want to put that fluid directly into the cardiovascular system. The risk of fluid overload, cardiac and respiratory, is too high. So he will more than likely have a BP shunt. So it will go from the ventricles to his peritoneal cavity. Okay, so here you go with this one. We have our assessment. You said you're gonna look at the BP shunt, you're gonna look at the site, what else? That's right. He has a BP shunt, so even though he's 2 years old, yeah, it's not the normal 2-year-old where you can say, oh, it's closed, I'm not gonna worry about it. Okay, he has a shunt. Okay, what else? How are we gonna do the hydration?
How are we gonna do what?
She said hydrate.
How are we gonna
How we gonna do it? You're right, the kid has gastroenteritis, dehydration, right? And vomiting and having diarrhea, so fluid balance will be off. The IV. What is it about this baby that you want to remember with your IV? Because it's not just gastro. You gotta think about this up here. That's right. Yeah. You want to make sure he has no signs of neurological issues going on. And if you do that calculation, is this the baby that you're going to round up your IV fluids? No. But you look at your child, you look at your assessment, you're like, no, this baby has, even though this baby has gastroenteritis, he also has a neurological problem that could make him fluid overloaded really quick and make this worse. So you're walking a pretty tight rope here, giving him exactly what he needs and not rounding it up. Huh? What else?
I get back to
Oh, that's causing the GI. Yeah. Okay, so we can do that. And let me say check his back.
Yeah.
Because he had that history of having that repaired. You want to look at that. Yeah, having it pain.
The shot in the medication, would you
especially if I have gastro, right? Because I got inflammation going on here. Is it possible? There you go. Is it possible that it has related to my BP shot? So my abdominal girth may be changing? Yeah, I might want to do an abdominal girth and get a baseline and then check it again. How about this? I'll plug it. Yeah, ml. Because if I'm giving you IV fluid because I think you're dehydrated, I don't want you holding on to it because of this, right? So I want to make sure you have adequate urine output. And what are you going to do with my parents? Oh my, whoever my significant other is. No, the parents.
Oh, the parents. I mean, we can check the parents.
So why do I need it?
If it doesn't have, I mean, if it doesn't fit, and then maybe it's holding because of the problem you know, so maybe we can do the catheter to join it.
So you're thinking this kid has a urogenic back? Could be. But remember intraumatic care though. Be careful with that. So I want to go straight to catheter. What other option do I have? No, back to what she was thinking. This kid's getting fluids. He has a history of repetion. Quite a bit for that. She's thinking he may have had a neurogenic bladder because of that. But we don't know that, right? So I say you have to be careful and think about intraumatic care. Unless we're sure this child has a neurogenic bladder, and the only option we have is to catheter him. We may want to put this child on strict ice and hose and observe. Are they voiding? They voiding the last hour? Because they just got to us. We may not have the full picture, So then the decision about doing in and out cath may be one that we have to ask parents. Has he been voiding his own at home? Is he just not voiding because he's so dehydrated? So if it's because of the spinal bifida that was repaired, that he has nerve damage, and maybe has been cath at home, then yes, we'll go ahead and cath him. But if the child has been voiding on his own, we have to rehydrate him first. I don't know if you hear people use the term challenge the kidneys, right? We give him a bolus of fluid and see what are they going to do. If he voids, we're fine. If he doesn't void, and we can do a bladder scan to see if there's not a urine in here, we can cancel it. Okay? So you're thinking nerve endings because even though I said lingual seal, and you're right, these kids can have some, maybe we thought it wasn't a lingual seal, we don't know. So we do our assessment, we find that the child has spastic lower extremities. They're not voiding on their own. They should be toilet trained, but they're not toilet trained. Those are all things that you need to consider along with their spinal bifida diagnosis. Okay? Even though now he's having gastroenteritis, so he's probably, even he was toilet trained, couldn't hold it, right? How many kids do you know? Well, I do know one. I shouldn't say that. But how many kids normally age 2, 3, if they had diarrhea, wouldn't have an accident? Even if they were toilet trained. My granddaughter at 2 got salmonella. There was a salmonella outbreak in Maryland. Nobody heard about it. Well, it was actually over the country, but Maryland. She got salmonella. She was in my car. We were driving to my house. They live in Laurel, and I live in Westminster. Where Westminster is? 10 minutes from the Pennsylvania line. And she's in the back seat in her car seat. Huh? Yeah. For 13 years, yeah. She's in her back seat, and I'm driving, and I hear, Mima. She goes, Mima, she's 2 and a half, remember? She goes, somebody's in my tummy and he makes doo-doo.
Oh, that's too cute though.
Took everything in me not to laugh. I'm like, oh my God, this is so precious. I should capture this on my class. So the next filling station I found, I went, ooh, does he have a bathroom? And I tell you, that child did not have an accident. I was so impressed. Here she was having bloody diarrhea. because that's what salmonella does. And I was like, and that's when I found out that the child was having bloody diarrhea, right? I'm in the bathroom in the stall with her in the filling station along the road, and she has this large bloody movement. I'm like, oh my God. Straight to the hospital we were going. And then, of course, it came back salmonella, but somebody's in my tummy. He makes 2.5 years old, so think about that. So your assessment here will really be important. Number one, if you know who you're assessing, remember your developmental stage, remember your milestones, what they should be doing. And then you've done the assessment skill, most of you have been signed off. So just remember we're talking about focused neurological assessment here. Now, do you need to do cranial nerves on this baby? Maybe. Maybe you do a modified assessment. Cranial nerve. If I have photophobia, you gotta be careful with perla checking, right? Does that make sense to you? Right?
Yes.
You want to know if the pupils are
It was
reactive, but you have to be very careful and do it as skillfully and as quickly as you can, because otherwise you can further increase intracranial pressure. Okay. And last thing I tell you, I've been telling everybody, we started this discussion in Open Lab yesterday about your charting. You need to know how to do your assessment. You need to document what you get. And nursing students historically have been, something about us that come into nursing. We've never been the kind of people who like to gloat about how wonderful and glorious we are. We always feel like we need to question what we're doing, you know? And so the nursing student might find something different than the nurse did before them, and they might say, oh, maybe that nurse was right. Maybe what I did was not right. I don't want you to question yourself like that. That's what your instructor is for. If you doubt what you've gotten on your vital signs, on your assessment, go to your instructor and say, I'm not feeling comfortable with this because I looked at what was charted before and I got something different. That doesn't mean you're wrong. That doesn't mean you're wrong at all. I actually had 2 people talk to me about this yesterday. I'm like, I might have to bring this up in my lab tomorrow. One of them was Ms. Armstrong talked a little bit about that charting. And then last night, I have a friend who's a nurse educator at a pediatric nurse educator at a big hospital. I'm not going to tell you that. And we were talking last night, and she said, you know what? I just feel so bad. I had 4, because people don't usually go into pediatrics like this. We're seeing more people coming in as new grads. Peds never accepted new grads. They want you to get some experience and all that good stuff. But now we're finding that when you go get some experience and all that good stuff, it's hard to unlearn that because you're so focused on the adult that you can't retrain your brain. So now they're taking new grads, and we may as well take our nurses and train our nurses. And so she was telling me they hired 12 new graduates, and 4 of them they had to let go yesterday. And my friend was just so distraught. She said, I cannot believe this. So I don't know. She said, she called me and she goes, Vivian, what are you guys doing in academia to those students? I said, what do you mean? She said, well, they come out here and they have no clue what they're doing. And I'm like, oh my God, are they our students? She said, well, I can't tell you that. She said, but I just need to talk to you for a minute. I said, what it is? She said, what is it? She said, I said, what happened? She said, the nurse, which was a very experienced nurse that admitted the patient, did her documentation and missed some very key things. The nurses after her never found it. Instead, they were charting exactly the same thing the nurse before them had charted. And it happened that 3 of them were brand new graduates. One of them had been on the floor 6 months, so I don't really consider her a new grad anymore. So she had 6 months or a year ago. And she said, but all 4 of them on 4 different shifts took care of this kid, and they all charted the same thing. So she said, my message to you, if you haven't taught this already, is with documentation, that is called falsifying the patient record. Because you cannot, in no way, even twins. Well, I'm going to pick on you, Christelle. Even you and your sister, you don't think alike. See? So you will never document exactly alike. So when you go and you look at it, it's so tempting because you're a student or you're a young nurse, you're learning, you're like, I don't think so. It took another new nurse, it was the fifth new nurse, who documented something that made everybody else look. And the nurse manager, because I guess the system is set up to flag changes, so at the end of the shift, if I chart that the patient had no temperature and no fever, and Ashley comes by and she said, oh, the child had a temperature of 101, they'll flag it. So the nurse manager goes in and looks at the flag records. And that's when she found that these nurses all charted the same thing. The entire assessment was exactly the same. The child has coarse rils, bronchi. The child has resonance clear. Everybody check. And nobody listened. Or either somebody listened or didn't believe what they got. So you will run into that as a new graduate. I can tell you that for a fact. You're going to stand there and you're going to doubt what you got. Because when you look at the people in orientation who've been teaching you, like myself, and I chart something, that's Mrs. Baruchi did that. It must be me. I told her, I said, my students don't even believe what I tell them. So I don't think if I chart it, they're going to take my chart. I think they're going to say I'm going to do my own one. I said, so I think that changes when they get into practice. I think it's a problem with the nursing practice and the new graduate. I don't think the student and the instructor has that kind of gospel truth. What you told me is gospel truth. That's right. So just remember that